All right, let's go ahead and get started. So, good afternoon, everyone, and welcome. My name is Amanda, and I'm DWDC's program coordinator. Today, I'm joined by my colleagues, Kat and Taylor. So, we'd like to begin by first acknowledging the land on which we gather here today is the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. These nations continue to experience ongoing colonization and displacement, and today Toronto is covered under Treaty 13 and the Williams Treaties. Dying with Dignity Canada is also mindful of broken treaties that occurred across Turtle Island and recognize our responsibility as treaty peoples to engage in a continuous process of truth and reconciliation with all peoples across this land. So I am thrilled to welcome you today to the fourth session of our series on myths and facts. Through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life topics alongside the professionals that know it best. Before I welcome today's speaker, I'd like to go over a few housekeeping items. So everyone on the call today is muted. However, there will be opportunities for you to submit your questions. To do so, please type your questions into the Q&A bar on the Zoom side panel, and we will read it out for you at the end. In the interest of time, we ask that you please try to keep your questions as concise and clear as possible. And while we're going to try to get to as many audience questions as possible, unfortunately, we may not get to everyone. If you have any outstanding questions or questions that are quite personal in nature, please email us at support@dyingwithdignity.ca, and we will follow up for you. This session will be recorded, so there's no need for you to take notes. And finally, there's also going to be a post-webinar survey that will pop up on your screen after the webinar and will give you the opportunity to share your feedback. So please stay tuned for that. And if you'd like to make sure you receive regular updates from DWDC on upcoming webinars, events, and advocacy initiatives, make sure you're subscribed to any of the social media platforms that you can see on your screen there. We're also going to be including a link to sign up for the DWDC newsletter in the chat, so keep your eyes peeled for that. Okay, and now to introduce today's speaker, we have the lovely Valerie Cooper joining us. Valerie is a hospice palliative care nurse practitioner with extensive experience in intensive care, pain management, and palliative care. She holds a Master of Nursing and Nurse Practitioner with adult certification from the University of Toronto and has worked in critical care, cardiac surgery, and emergency medicine. She's currently with Ontario Health at Home and is certified in hospice palliative care nursing and actively contributes to education at the undergraduate and graduate level, as well as continuing education for nurse practitioners. Valerie is also involved in multiple communities of practice focused on palliative and end-of-life care, and that includes medical assistance in dying, and also currently serves on the Dying with Dignity Canada Clinicians Advisory Council. So Valerie, thank you so much for joining us.
Thank you for having me.
Of course. So audience members, before we get started, we're actually going to begin with a poll to test your knowledge. So in just a few seconds here, you're going to see a window pop up on your screen that'll give you the opportunity to answer the question that we have. And for our audience members that might be sight impaired or joining by telephone, I'm going to go ahead and read that question out. So our poll question is, what is the top cause of death for Canadians today? And we've got four options listed. So we have heart disease, cancer, Alzheimer's or other dementias, and finally, lung diseases. So we're just going to hold off for about another 15 seconds here. Then we're going to end the poll and we're going to share the results with everybody. Okay, let's go ahead and close that poll and share the results. All right, so we can see here that about 57% of our attendees answered heart disease, 28% said cancer, 12% said Alzheimer's or other dementias, and the remaining 2% said lung diseases. So, Valerie, what's our answer? What's the top cause of death for Canadians today?
Actually, cancer is the number one cause of death, followed by heart disease. So flip of our poll answers. But yeah, those are the two main contributors. Um, Alzheimer's and lung disease are less common as causes of death, but many individuals have multiple diagnoses. So it's not always just one thing that is contributory to a cause of death.
All right. Thanks so much, audience members. We'll have a few other polls interspersed throughout the session, so keep your eyes peeled. So, Valerie, let's go ahead and dive right in. Some of the leading causes, as we've just seen on that poll, are cancer, neurodegenerative conditions like ALS and heart disease. Dementia is a growing concern for many Canadians in their end of life care and quality of life. I'm curious if you could share a bit about the dying process or some of the common patterns of dying that looks like when a person has that specific medical condition. So, for example, what are some of the common patterns or dying process for somebody with ALS?
So, in palliative care, we kind of talk about three different dying trajectories. So, there's a trajectory that's closely followed by most end-stage cancer diagnoses. There's another one followed by end-stage organ failure. So, that would include ALS or neurodegenerative, as well as COPD, so chronic obstructive pulmonary disease, or interstitial lung disease, so end-stage lung failure. And then cardiac diseases, so heart failure, so end stage heart failure. Those sort of end stage organ diseases follow a similar trajectory. And then dementia has its own trajectory. So I'll start with cancer just because it's a bit easier in my mind, to go through the three of them. So a cancer diagnosis, generally someone has fairly high functioning, and I'm a hand talker, so I'm going to use my hand because this is how I describe it to patients and families. They're functioning. So function is on the y-axis and time is on the x-axis. And so cancer patients generally function at a fairly high level for a fairly significant period of time. So that may include a few blips here and there with treatment and symptom concerns, but generally they're pretty high functioning until they get to a point where they're not. And then that decline is pretty steady. And we often say that when somebody becomes functionally to a point where they're no longer able to get out of bed on their own, they're in the last 3 months of life. And it's quite accurate in predicting someone's prognosis for an end-stage cancer diagnosis. So generally, if functioning is really high, the functioning is going to continue to be high. And once it starts to decline, then we know that things are going to continue to change at that rate. Contrast that with end-stage organ failure. So regardless of the organ, it looks a lot more erratic. So higher functioning, they get a diagnosis, usually with an exacerbation. So usually a hospitalization or some sort of acute medical event that results in diagnosis. And when they recover from that, they never actually get back up to the level of functioning that they had prior to that first dip. And then they go along and they're functioning pretty well. And then they'll have another exacerbation or another hospitalization or another acute medical event. And again, they won't get back up to that functional level that they had before. And so the number of blips on that trajectory looks sort of vary from individual to individual. And the important part for people to understand is that at the bottom of each of those blips, decrease in function could actually be death. The medical event could be so significant that somebody may end up dying, but we don't know which one, right? Whereas with cancer, when someone's progression or function starts to decline, we're pretty sure that they're at the end of their life. And so for end-stage organ failure, that functional decline can continue with many, many, many blips until functioning is quite low. And that time could go on for quite some time. And then the third trajectory is dementia or frailty. And that's generally where the functional level is quite low on the scale. And that low functional level lasts for quite some time. And it has little blips here and there. So, a pneumonia or a urinary tract infection or a fall. And so there are some blips which could end up being a terminal event, but that we don't, again, know when that terminal event will happen. And because their level of functioning is so low for so long, we don't really know when dying is going to happen.
Yeah. Okay. Thank you so much for sharing. For my next question, as death approaches, what happens to each organ system in those sort of final days, final hours, final minutes? I'm wondering if you can sort of break it down.
Sure. And so the answers I just gave for the first question are help to differentiate what the dying process, like the time before dying, leading up to acute dying, looks like and how it differs from disease to disease. But generally, the actual acute dying, the last few days, hours of somebody's life look very similar, regardless of what the underlying reason or cause of death. And so there are a lot of things that we can teach and educate family and healthcare providers that are supporting somebody who's dying to be able to look out for that are part of the normal dying process. And I often compare dying to the process of giving birth. So I often describe that if you're pregnant with a baby, a woman's body knows how to give birth. Even if the woman doesn't know anything about the stages of labor or the things that are happening inside her body will birth that baby. And conversely, at the end of life, our bodies know how to shut down and how to get ready to die. And what we need to do as generally, sometimes as the patient, if they're aware enough and care to know this information, but mostly as the family and healthcare providers supporting, is around what is a normal part of this process and how can we respect what this body knows how to do and not get in the way of it doing those things. So, for example, I talk a lot about eating and intake at the end of life. And so, as somebody's body gets to, even in the last weeks of life, and especially last days and hours, people don't want to eat or drink because their body doesn't need sustenance any longer. Their body isn't in a place where it can metabolize and break down things that we're putting into its gastrointestinal tract. And so people have no interest or desire for food. And that can be really stressful for patients and for families, especially because in most cultures, feeding and providing food is a way to care for somebody. And when an individual no longer has interest in that, it can feel like we're at a loss as to how to care for that person. And so going back to the respecting the body, that this is what the body is telling us, that it doesn't need these things anymore. It's not because the person's not trying hard enough to eat or, putting enough effort into, putting in food and sustenance and things that historically through our lives have been important, but rather we need to listen to that body that it doesn't need these things anymore. And then along with that is elimination. So because we're not putting much in, we're not putting much out. So urine output decreases significantly. Somebody may not have bowel movements for a number of days. And as long as those things aren't causing a patient or an individual discomfort or creating new symptoms, then again, that's part of the natural process of the body shutting down. And we don't need to worry about that. Some other things people might notice are changes in breathing is a very common significant change that families will notice. Changes in the rate of breathing and perhaps pauses in breathing. So I'll often demonstrate for families that a patient may and then pause and then and we call that chain Stokes breathing. And that really is a very primitive brainstem reflex. And although the sound of a big gasp in can be very distressing for people who are listening to it, because we associate that with, diving into a pool and barely making it to the surface before we can get that breath in, and we feel so, I don't know if we're going to make it. And yet, when someone's doing that at the end of their life, they have no conscious awareness of that feeling. The body is asking them to take that breath in, literally because the levels of oxygen and carbon dioxide in their blood are so out of whack, likely from ineffective respiration, so gas exchange over a number of hours or days, that the body's basically saying, you need to take this big breath in or else you're going to die. And so literally it's a response that the person is unaware of. They are not doing it because they feel this. Their literal respiratory muscles are causing that big breath in, but understandably can be very distressing for family. And so helping family and healthcare providers who are witnessing this to know that this is part of the dying process. It's very normal. It is will and likely can continue to be upsetting for you to listen to, but knowing that your family member isn't distressed by this, it doesn't have the same awareness. They don't have the same awareness that you do. Sometimes we'll see changes in the in the cardiac system, so changes in body temperature, very sweaty and hot in the torso and the head, and cold, cool extremities, or even mottling, which is like a purpley bluish discoloration to the extremities. Again, the body's shutting down systems that it doesn't need anymore, and it's keeping the blood and circulation central to the important organs and less so to the extremities. So again, disconcerting for family if they don't know that that's part of the normal process.
Yeah. Thank you so much.
Mhm.
Next question. Actually, not next question. Let's go ahead first with another poll to test our audience's knowledge. So we're going to go ahead and launch that poll. You should see it on your screen shortly, and I'll read it out for our audience members. So this is a true or false question. True or false, the death rattle always occurs when a person is dying. So, audience members, let's go ahead and see your answers. Is it true or false? And again, we'll just hold off for about another 10-15 seconds here, and then we'll go ahead and read the results. Okay, perfect. Let's go ahead and close the poll and share results. All right, so about 84% of our attendees said that this is false. It does not occur always when a person is dying, and about 16% said that that is true. So, Valerie, what's the answer?
It's false. It doesn't happen for every patient. Um, we use the term here, death rattle, as a colloquial term, but generally in healthcare, we try not to use that term because it can be understandably upsetting. And this is often the thing that sticks in people's minds about sitting vigil with a family member at the end of life is the sounds. And I actually just described this to a family this morning, where the sound comes from. And it's actually the best description I have heard, and it came from somebody else, so I can't take credit for this, but when you're drinking with a straw and you get to the end of your drink and you hear the sound of the sucking up air along with the water, and that's that's what's happening across somebody's airway. So in our upper airways, we have bigger tubes that the air travels through. And sometimes when we're not conscious of clearing our throat, like I just swallowed right now, we do that hundreds, if not thousands of times a day, subconsciously without effort. When somebody loses the muscle strength and ability in those throat muscles to clear those secretions, as one does at the end of life, that fluid that we would normally clear without even thinking about it sits over the airways. And so every time somebody breathes in, that fluid or that mucus rattles a little bit or makes a sound when the air passes over. And so by virtue of the fact that the person is as unconscious and unaware of that sound, shows you that that's exactly what's happening. They don't even know that they need to clear their throat. And so actually the best treatment intervention to address that sound, which again is much more disconcerting for people listening to it than it is at all for the patient who's experiencing it, is repositioning. So if we move the head of the bed up or down or turn a patient side to side a little bit, then that can help to dislodge that fluid that's sitting across the airway, move it down or up, or get them to swallow a little bit with the movement. And then it clears that sound away. We do have medications that we can use in a setting where the sounds are coming more from the oropharynx, so the back of the throat and the mouth. So this may be most appropriate in patients who have ALS and who have significantly lost their swallowing ability, but continue to produce quite a lot of saliva, or a normal amount of saliva, but don't have the ability to swallow and deal with it even earlier on in their disease trajectory, not necessarily just at the end of life. But those medications that we use are actually, we're using the side effect of the medication, which is a drying side effect. So it basically causes dry mouth. So an anticholinergic effect of those medications to dry up the oral secretions. But it's not very common that the sound is actually coming from oral secretions. It's more likely coming from upper respiratory secretions. And so that's why the repositioning can be the most effective to deal with that. But sometimes families want something to give. They feel like they're doing more about something. So we'll institute medications at that point if the family feels that may be worthwhile, more in order to treat the family's anxiety about this symptom rather than treating the actual underlying issue for the patient. But we also want to make sure that we're not worsening a symptom. So I always ask the family, has your loved one had issues with dry mouth with medications through their illness journey? Because dry mouth is pretty much a side effect of every medication. And if they say yes, that was a huge complaint for them, they always were sucking on candy or had, a sip of water to help with their dry mouth, then I generally try to stay away from medications that are just going to create that issue again with dry mouth without actually addressing the underlying reason why this sound is happening. And again, I think the education and the informing people as to why this sound is happening and the fact that their loved one isn't bothered by it because if they were, they would clear their throat or try to swallow, then it helps the family to be able to come to terms and to cope a little bit better with that.
All right. Thank you so much. Now we're going to switch topics a bit and talk about families and loved ones. And can we start off with perhaps, could you explain what vigiling is? Or, for a family sitting vigil, what can they expect to experience with their loved one who's sort of in that final day, final hours of life?
Yeah, so sitting vigil is being present and bearing witness to dying. And it's something that in our Western society, we haven't done for a really long time, most of us. There are many senior citizens who I support as their parents are dying. So people who are in their 60s and 70s who are supporting their, 90-year-old parents to die, who have never actually been present when somebody is dying. Because for the bulk of the last century, medicine stole dying from communities. And prior to that, in the history of human beings, we all knew what death looked like and what death was like because we were physically present with it and bore witness to it through all of humanity. And so we're really coming back to learning what dying looks like and what dying is about as a society. And so for those of you that are here today that have an interest in this, I commend you because there are so many people out there who haven't had an opportunity to learn some of these things that at one point in humanity would have been second nature. And so being present when someone is dying is, in my view, a gift to not only the person who's dying, but also a gift to the people who are doing the witnessing and doing the supporting. Because if we can get symptom management well done, if we can get the supports in place to allow the family to feel supported in supporting their loved one to die at home, we can create beautiful memories of a very sad time in their lives that they will carry with them until they're dying. And if we do a good job at making death as good as it can be for that family and that patient, then we're doing a lot as a healthcare system and as a society to lessen our fear of dying and our reluctance to talk about dying and death. And so I often point that out to family members and to patients themselves if they're able to participate in conversations with me at that point, that this is a gift that they're giving their family by allowing them to see what this is like and to learn these skills and how to cope with something that's really hard, right? Even in the best dying, it's still sad. And it's supposed to be because dying and grief, the grief of dying is a reflection of the love that families had for this person. And so having the opportunity to be able to reflect that love back to this person. My favorite situations, and I was just in one this morning actually, is when a dying person is in bed surrounded by their family members and their families are telling stories and looking at pictures and laughing and life is happening around this dying person. It's such a beautiful moment to be a part of, and I feel privileged when I'm able to be witness to such situations.
Yeah. Wonderful. Along that thread, I think it's clear from what you've said the importance of loved ones being able to attend an individual's sort of death and dying process. So I'm curious then for our next question, how do patients, as well as their loved ones, sort of emotionally prepare for the dying process? We talked a little bit about the different stages that somebody can expect in a dying trajectory and how that brings some comfort to families to know what to expect. But I'm wondering if you have any more insights on, how do you prepare emotionally for that beautiful but sad moment?
Mhm. Well, I think the first step is acknowledging our mortality long before we're faced with the actual event. And so for patients and families that I get involved with, it's generally when their function is starting to decline. So we're starting to move towards the patient needing more help with things, having more evidence of disease and symptoms of disease. And so we know that death is going to happen. We don't know when, but we know it's going to happen. Pardon my loud cat in the background. But when we know what is going to happen and when we come to terms with that, and so I often say, when you've come to accept that you are in the last bit of your life, and accepting is not necessarily that you're okay with it, but that you've come to realize that this is what's happening. This is where I'm at in my life. That we can have open conversations about how to prepare, how to plan, how we're feeling about this situation without having to worry about, overstepping boundaries or saying the wrong thing or, talking about something that everybody hasn't come to terms with yet. And that makes it really challenging when someone or somebody within the family really can't acknowledge where things are at. And I mean that happens and we have to manage it and meet people where they're at. But I think for me the most successful, and that sounds odd, but the most successful dying times are when there's no elephant in the room, when we can talk openly about what's happening, we can make plans. We can be sad that we're making plans for this. Like just because we do the things doesn't mean that we can't have the emotional responses to them, right? And so taking a moment and saying, I'm sorry, this is so hard. I'm sorry we have to have this conversation right now. And I'm sorry that we have to put these plans in place. And just acknowledging that I think is really important. But on the other side of that, planning ahead and knowing what's to come as much as we can and allowing the person who's dying to be a part of that is really empowering for them. Um, when someone's given a life-limiting diagnosis, they're basically robbed of their control and their ability to plan and have a say in what the rest of their life is going to be like. It's very up in the air. And so when we get to a point where we know somebody's going to die, we can give them back some control. They have a say in what this next little bit of their life looks like, or what are the things that they want to focus on? What are the things that are important for them to do in this time? We can do things like legacy work. So planning ahead for when they aren't here, how do they want to be remembered? Who who do they want to give their things to? What are the things that matter the most to them that they want their family to take with them after they're gone? And if we can't talk openly about the fact that they're dying, we can't do any of those things. And so it's really a gift to be able to speak openly and plan and provide opportunities for sharing emotions. You know, I'm definitely not a Pollyanna type person, but I think I find it ironic in myself that I can find so many beautiful, positive things that can come out of somebody's dying time. And so I think that's part of my role, and part of palliative care's role is to help people to see that it can be sad, but it can also bring wonderful, beautiful things.
Yeah, thank you. As a follow-up question to that, I think it's clear what's effective in providing comfort and clarity to patients and their loved ones. But I wanted to touch on what you'd mentioned about conflict, or again, about individuals that are perhaps not ready to accept whether they themselves are dying or their loved one is dying. And I'm curious how, as a palliative care provider, you approach that, and how you try to make that individual feel more comforted about the aspect of death, or at least to keep them involved in that difficult process.
Mhm. It's challenging. And I think that's one of the biggest challenges in working in palliative care is seeing how good things could be if, you know, somebody could come to terms with what's happening, if we could have open conversations, if we could get the help in the home that we needed, if only this person would accept this intervention. And so I think being able as an individual to take a step back and say, this isn't about me at all. This is about this family and this individual and their journey, and supporting them to make the choices that they need to, but allowing opportunities over time to explore sort of where this is coming from, right? I had a family a couple of weeks ago that when I came for my first visit, this patient was very clearly near the end of their life, much nearer the end of their life than I think their family realized. And I felt that it was really important to have some really tough conversations in that moment, because I was very concerned that this person would die without the supports that they needed in the home in order for that to be as peaceful and non-traumatic as it could be. And we talked about, things like do not resuscitate and funeral homes and, pretty pragmatic things. And a family member said to me, you know what? The patient would be shocked at this conversation that we're having, because he wasn't well enough to participate. I said, what do you mean by that? And he said, there's no way that the patient thinks that this is what's happening right now. They have no concept that they are this close to the end of life. And so I took a moment to sit with the patient and hold their hand. And I said, what do you think is going on right now? And had tried to have as much of a conversation as I could with this individual. And they were able to respond to me, I'm not well. I don't feel well. And I said, things have changed quite a bit recently, huh? Yeah, they have. And I said, last week you were driving and you were out of the house doing things. Do you think that you're ever going to be able to do those things again? And they said no. And so their family hearing that, I think, as sad and hard as it was to hear their loved one admit that they were aware of what was happening, that was really helpful for the family to appreciate that, in fact, they do know that they're at the end of their life. And in their heart of hearts, they are aware of what's happening. And I hope that knowing that their loved one was aware of what was happening and what was going to continue to happen, it allowed them to come to some terms, despite the fact that things had changed so quickly and it was obviously feeling very overwhelming for the family. But really just providing those opportunities for people to really think and say things that are hard, right? I think we as humans think very much that if we say something or talk about something, then it's going to happen. And the reality is, if we don't talk about it or don't say things, it just makes what's going to happen anyway that much harder. But it's not, I often talk about dying as not, it's dying isn't necessarily a Hallmark movie, right? Where everything is wrapped up and pretty and tied with a bow at the end of it, right? There are situations and families that I have supported that where it hasn't been as ideal as maybe it could have been, but that's their dying and that's their family, and respecting that is really important too.
Okay, thank you. For next question here, you know, we often hear or, see in those sort of Hallmark movies, as you mentioned, that a dying person might be waiting or holding on until a specific individual, or it might be, a small milestone arrives before dying. I'm curious if this is something you've observed, and what are your thoughts?
Yeah, it is. There are so many things that happen in the sometimes months and weeks and hours leading up to somebody's death that are really unexplainable. I'm a very scientific based, logical person, and I find it very intriguing that there are still parts of what I witness literally every day that I can't explain. And that's one of them, that people hold out for somebody to come. They are literally could die at any minute and yet hold out for, hours, days until somebody arrives, or until the people who have been sitting vigil finally go home to have a shower or finally go get a coffee. And as soon as they step out of the room, their loved one is gone. Um, there are, deathbed visions. There's different terminology that people use in describing them, but seeing people who have died before. I have seen so many times patients who are confused to their family, confused to their healthcare providers. But I've learned that if we take what the person is saying and look at it in a context that is makes sense from where they have been in their life before. So maybe in a different city, in a different house, with different people, that their confusion becomes a story, becomes a memory of something that they have lived before. And so I have a story of a husband whose wife kept saying, you need to get the animals out. Take the animals out of the room. I take the animals outside. They can't be in here. They had one dog. And he's like, I don't know why she keeps talking about these animals. And I was like, well, you know, did you have more animals at some point? Or like, did she grow up on a farm? We were in a rural setting. And he said, oh, yeah, she grew up on a farm. I was like, well, did they have lots of animals? She's like, yeah. And her job was to take the animals out to the pasture. Like, that was her job, to shoo the animals out of the inner field to the other field. And he's like, oh, okay, that makes sense. And another patient who talked about their three kids, but they had two kids. And I said, that's interesting. Did you lose a baby? Did you have a miscarriage, or did you have a child that died? And the light bulb went off in the husband's face, like, we did. We lost a baby during pregnancy. So just it seems like confusion because it doesn't make sense for the here and now. And yet when you change the perception of what this person is saying and put it in context from their life previously, it makes sense. And so I see that very frequently, and the deathbed visions of seeing people who have died before and talking to them. And I describe it as the psychological work of dying. So people are not where we are, and we won't be where they are until it's our time. But when you see it enough, you see this consistent evidence of this work that is happening in people's brains as they are getting ready to go wherever they're going. And yet it's so consistent across beliefs and people and diseases and situations that there has to be something more to it. And it's unexplainable.
That's so interesting. Thank you for sharing. Okay, audience members, we're going to take a quick break and start with another poll. So you'll see it pop up on your screen in just a moment here, and I'll read out the question. So, true or false? You should not speak to the dying person if they are in a coma type state. So we'll get your answers shared in just a moment. Do you think it's true? Do you think it's false? And we'll sit tight for just a moment and get everybody to answer. And might as well, while we're waiting here, Valerie, what's your cat's name?
I have three cats.
Oh,
Paxton, ET, and Gertie. And
Wonderful.
Paxton and ET are chasing each other around. So that's who you hear in the background.
All right. Fantastic. Well, love to hear them in the background. All right, we're going to go ahead and end the poll and share. All right. Wow, that is quite a decisive majority. So, about 90, quite literally, 99% of folks said false. You can speak to the dying person if they're in a coma type state. And about 1% said that this was true. So, Valerie, what's the answer?
I won't shock anybody here by
Yeah,
saying it is not true. Please
false.
talk, please talk to people when they are unawares. And as an old ICU nurse, it comes naturally to me because we talk to our patients even though they're in a medically induced coma and on so many medications and on a ventilator, and because they're still a person, right? And even actually, I was just doing some teaching with undergrad students, nursing students last week, and we talked about, talking to patients, talking to bodies when we're doing postmortem care. It's a sign of respect. And so it's also a way to comfort ourselves, right? And sometimes those are the things that need to be said, and those are the moments in which they should be said, and the opportunity that they get to be said. So when, you aren't, you're not waiting for a response, or you don't need a response. You just need to say the things that are sitting in your heart. Dr. Ira Byock, he's a very famous palliative care doc in the States, and he wrote a book called The Four Things, and the four things that people need to say and do before they die. So, I love you, forgive me, I forgive you, and goodbye. And
Wow.
so some of those things that a dying person needs to say, we as the people who are remaining also need to say. And sometimes it's easier when we can say them when someone isn't aware. So saying those things, reminding people that they're not alone, right? I think that's one of the biggest fears as humans is to die alone and to die without anybody knowing, right? And so being able to remind and reassure someone who is in the dying process that they're loved and surrounded by people who care for them and that they aren't alone, can be really powerful, and I think is something I often suggest to families, that when your loved one, if your loved one looks uncomfortable or starting to get restless or agitated, the first thing to do is to take their hand and to let them know that you're here. And often that is enough. We don't need to give medication. We don't need to do anything more technical than that. And just being present and letting somebody know through touch and through sound and voice that you are present with them in this time is really powerful. So yeah, and the old um, adage is that the hearing is the last sense to go. We don't know definitively. Nobody knows that that's true or not, but I think it's worth trying out. There's no harm in it, and it definitely can bring comfort to the person who's doing the talking just as much as the person who's hopefully hearing.
Yeah. Thank you. For next question, can you share a little bit about what someone may experience cognitively while they're going through that dying process? Perhaps in that, again, that last day, last hour, last couple of minutes.
I often will, I guess, warn or educate families about, somebody may have been really, really sleepy for a significant period of time. That's one of the signs that somebody's getting close to the end of their life, or they're sleeping much more than they're awake, 20 plus hours and eventually 24 hours a day. And sometimes so deeply that it's really hard to wake them up. Even if you wanted to wake them up, they're almost in a comatose state. And yet they may wake up one moment and open their eyes and say something completely rational and ex totally fitting to the situation. Like, where's your husband? How come he's not here with you? Or, you know, I want a cup of coffee. It's 10 o'clock in the morning. I want my cup of coffee. Something that's completely lucid and makes complete sense. And you're like, how? I literally couldn't even get you to even remotely acknowledge that I was here, and I was yelling in your ear and had my hand on your chest, and you weren't doing anything, and yet now you're wide awake. And so that flip from being so quiet and somnolent to being wide awake, that wakefulness won't last very long, but taking advantage of it when you have it, like taking that moment to be like, look at who's here with you. And like, I'm so glad that we get to see you and hear your voice. And, just making the most out of those moments when somebody is awake, because we don't know how many of those they might have. And that literally may be the last time. And so just recognizing that fluctuation in consciousness can happen in the last little bit. But for the most part, people are generally sleeping and almost comatose for the last part of their lives. They'll often, as I mentioned, talk about people who have died before or situations that they've been in before. You'll often see grabbing, reaching out, or grabbing up at things. And again, families are often quite disturbed by that. They're restless and they're agitated and they're grabbing at things like they must want something, but it's a very common thing to see. We don't know why, but taking their hand and letting them know we're here. You're not by yourself. Everybody's surrounded. We're looking at pictures. We're talking about this story. But remember when this happened? Like those are the moments to have those interactions with somebody, even if they're not able to respond to you. But it is the great mystery of what people are going through in that time, and at some point we'll all experience it.
Thank you. All right. Next question here. We're going to start with a poll first. This is our last poll of the day, folks. So pull it up on our screen in just a moment. And this is our last true or false question. So, true or false, palliative care should be started when a person has less than 1 month to live. So we'll see in just a moment here. Everybody's very quick in putting in their answers. So thanks so much, audience members, for the engagement. We'll hold off for just a few more seconds here, let everybody participate, and then we'll share the results. Okay, just a few more seconds. All right, let's go ahead and close the poll and share. Okay, so we have about, yes.
Yay!
So we have about 12% of folks who say that this is true. So palliative care should be started when a person has less than 1 month to live, and about 88% who say that this is false. So for the last time, Valerie, what is the answer?
False. Big fat false. This is a really common misperception, I think, because palliative care does encompass end of life care. So if somebody's in the last month of their life, they likely require more end of life care focus than just palliative care. Palliative care is a much broader type of care that actually should, and in most cases, would benefit a patient from being started at the time of diagnosis of a life-limiting illness, because palliative care is about living as best as you can for as long as you can. So, really good symptom management. It can happen alongside disease modifying and even curative treatment. Palliative care is really about holistic, focused on patients' goals. Goal concordant care is another way to think of it, and should not be limited to just the end of somebody's life. Definitely, if palliative care hasn't yet been involved and the person is in the last month of life, by all means, palliative care should be getting involved then. But ideally, we should be seeing palliative care. Patients should be seeing a palliative care provider or a practitioner, like a family doc or a specialist who is able to provide what we call a palliative approach to care. So palliative care is interesting because it's both a specialty, like I'm a specialty palliative care provider, but it's also a general approach to care that can be provided by family docs and nurse practitioners and cardiologists and respirologists, because it's really just good care. It's thinking of a patient, seeing a patient as a whole person with a bunch of different parts that matter to them, and helping them to live the best life that they can for as long as they can. And a small part of that is end of life care that we focus on when somebody is clearly at the end of life, but it's not all that we do.
Okay, thank you. Next question. Speaking from your perspective as a medical practitioner, what are some of the approaches that a healthcare provider or a healthcare team may take in order to keep a dying person comfortable?
Well, I think, taking an overview of sort of how everybody is coping in the situation. I was at a talk last week where there was some data shared about preferred places of death for individuals, and that, a lot of people will say that they want to stay at home, not realizing that being at home has a lot of implications for the people that are supporting that person. And so in order for the patient to be comfortable at the end of life, we do rely, and I speak as a home care provider, we do rely on family and friends to come together to provide the bulk of the care for somebody to remain at home and be comfortable and safe. So I often describe, if it's not, although the patient is at the center and the focus, the plan has to work for everybody involved, or else the patient isn't going to be able to remain at home. And so making sure that we get as much support as we can through the public system, looking to private pay if that's an option, looking to extended family in order to make sure that everybody is coping in order to keep somebody safe at home. Because, being at home means that we most likely have nursing visiting once a day, maybe twice a day, but that the family is providing medication administration, repositioning, doing personal care, like toileting or changing briefs. So there's a lot of aspects of keeping somebody comfortable at the end of life that fall to the family. And so making sure that they're capable of that is really important. And then different settings have, so like a hospice resident setting, some of them may have the family providing some care with paid professionals providing more care than at home, and other settings, other hospice residences or palliative care units may have providers that are around 24 hours a day and can take on that caregiving role completely and allow the family to be present with their loved one while they're dying, just as their loved one, as opposed to also their nurse and their PSW and their occupational therapist. But we, regardless of where the individual is physically at the end of life, we use a variety of different medications focused on symptom management. So, most patients die with some amount of opioid pain medication for both pain or breathlessness. Sometimes a bit of anxiety medication to help with restlessness or agitation. Not everybody has oxygen at the end of life. It's not always necessary. Oral medications that somebody may have been taking for other comorbidities like hypertension or cardiac disease or puffers, those things are no longer a priority for the patient as far as using their energy to take pills, and they lose that ability eventually anyway. And puffers, they're not able to take those. So those kind of other medications are no longer a priority when someone gets to the very end of life, and we focus mainly on making sure that somebody is physically comfortable, is psychologically comfortable, and has the equipment and supplies, and their family has the support that they need to be comfortable.
Thanks, Valerie. As a follow-up to hone in specifically on dying at home, I'm curious if you can break down, some of the steps that a family ought to take when, a loved one says, okay, I've only got a week or a couple of days left before I die, and I want to die at home. So let's say they're being transferred from an acute setting into the home. How do loved ones sort of prepare that person to make sure they're comfortable at home, that this individual can die, in fact, at home, and then what are some of those immediate steps right after somebody has died at home?
Yeah.
Do you need to call a coroner right away, funeral home, that sort of thing?
Yeah, so I think ideally we'd be having these conversations before the week or days before somebody dies, but yes, those situations do happen. I think equipment is really, really helpful. Occupational therapists are some of my favorite people, and making sure that we have the right supportive assistive devices in the home as somebody's function declines, to make sure that they're able to maintain their independence for as long as possible. But close to the end of life, most people will need a hospital bed as the main piece of equipment, perhaps a commode if they're still able to transition to a commode. Sometimes people need a urinary catheter that the nurses would insert, and so some teaching along with that. Incontinent briefs, so some of the personal care concerns. It's less about whether the patient can die at home and more about whether the family can cope with the patient dying at home. And so sometimes, when I'm chatting with families and patients and we're making a plan, and I ask them, where would you like to spend the last little bit of your life? And most people say at home. I say, okay, and like, do you want to die here in this home? Is that part of the plan? And most people will say yes. Some people will say, no, I want to stay here until, I'm a couple of days from dying and then I want to go somewhere. And that adds its own complexity of trying to pinpoint that and make arrangements to go somewhere. But I think I always follow up with, okay, well, if you can't die here at home, if things aren't working, would you consider going someplace else and looking at sort of, I call it the plan B. What's the plan B if dying here at home isn't going to be feasible? Either because you have symptom concerns that we're struggling with managing, or your family isn't coping and we're not able to get the supports that they need in order to keep you here, just that we have another option, just so it's on the table, because often family, they feel guilty when they're not able to keep somebody at home if that was their wish. And it's almost never the family's fault. It is almost always the system's fault for not being able to support them in order to make their loved one's wish of dying at home come true. And so I think just talking about it early means that we can alleviate the guilt from any party feeling responsible for that. And rather, here's the plan. We're all going to do what we can to make this happen. But if it can't, we have another plan and we've talked about it. And everybody is aware that might need to be the option in order for people to cope. And I think helping families and patients to see that at the end of life, it's all about supporting one another and reflecting on the love that we have for one another. So a family member will often say, like, I love this person. I'll do whatever it takes for them to stay here at home. I'll do whatever. And then the patient will say, well, I don't want you to stress out about this, and I don't want you to have to do these things for me. And really what I hear then, and it's reflected often in MAID assessments, is this concept of being a burden. That's the reflection of love that these two people, or these two groups of people, have for one another. That you love somebody enough to do whatever they need for you from you to allow them to stay at home or to make this choice about MAID. And the person who feels like a burden loves their family enough to say, I don't want to do this to you. Right. And so being able to have those conversations openly about what the plan is, if plan A isn't going to work, what's plan B? When somebody dies at home, and I'll speak to my area in Ontario, I believe it's similar. I believe there are expected deaths in the home protocols in all provinces and territories. But if it's an expected death, so palliative care is involved, the plan is for the person to die at home. There is documentation in the home. In Ontario, it's called a do not resuscitate confirmation form that speaks to not starting CPR or defibrillation when someone's heart stops. Then the family would call the nursing provider agency when they have determined or think that the patient has died. There is no rush to that. There is no time frame to when nursing needs to be called. So I'll often say, if it happens in the middle of the night and you just can't deal with staying up to wait for the nurse to come, then you don't have to call in the middle of the night. We know this is going to happen. It doesn't matter when exactly you notify people. Conversely, you can call the nurse in the middle of the night and have everything taken care of as soon as possible so you can be done with it. Same with after the nurse comes to do the pronouncement, and I put it in quotes because by the time a nurse gets to a home, we're talking about, potentially hours since the patient actually died. So it's pretty obvious that they have died. They will let the family know that they can call the funeral home, and then the funeral home will come and get the body or the cremation service. And again, the time frame of that is whatever the family needs. So if they have loved ones coming to see the person, and the person has known that was going to happen and they're okay with that, again, a thing that should be discussed beforehand, that they can do that and the funeral home can come whenever the family is ready. So it's not urgent. Nothing about that process is urgent unless the family needs it to be, and then it can be. But the whole point of talking about ahead of time and planning for an expected death is that it's really based on what the family needs and not any outside interventions. So ideally avoiding 911 being called, police and ambulance showing up, miscommunication about what the goals were. We want to make sure that families feel secure in who they're calling and when they're calling based on their family's needs.
Absolutely. Thank you. We're going to wrap up here before we move to the audience Q&A. I wanted to check in, what are sort of three top pieces of information or advice that you want, audience members watching today and watching the recording later on to leave with today? So kind of your top three.
Only three.
Only
Okay.
three, yes.
Um, dying is part of life, and the more we can normalize that, the easier this hard thing that will always be hard, the slightly easier it will be. Be open with your loved ones about what you want, what you think you want, as early as you can be, so that we can make plans. You and your family and your healthcare team can make plans to help support that and to figure out, like, okay, if this is what you want, then these are the things that we're going to need to think about, right? And not leaving it to the last minute. Planning ahead is definitely helpful. Especially if you know what you want, and if you don't know, asking and having those conversations, even if your healthcare team is a bit reluctant to have them, sort of pushing forward and discussing those hard things again is really important. Um, and to try to find the beautiful parts in the dying process, and the memories and the good things that you'll look back on and remember, so that you can carry those with you through your life and into your dying time.
Well said. Valerie, thank you so much. That concludes our interview portion of today's session. So we have a lot of registration questions and Q&A questions. So thank you so much, audience members, for submitting these. So let's go ahead and get started. This audience member is curious. Is it necessary to die in a hospital in order to donate your organs? And they ask as a follow-up question, for example, if you were having MAID or medical assistance in dying at home, can you still donate your organs?
Great question. So, in most jurisdictions, yes, you would need to be in hospital in order to donate organs. Um, every province and territory has an organ donation organization that helps in Ontario. It's called the Trillium Gift of Life Network. And they are becoming more and more comfortable and familiar with the process of organ donation after a MAID death. A lot of expected deaths outside of the neuromuscular, so like ALS diagnoses, are generally, and this is a generalization, every case is specific case is different, but would be less likely to be able to donate organs by virtue of the fact that the individual's organ systems have likely been impacted by their life-limiting diagnosis, like cancer or heart failure or lung failure. But there have been cases in larger centers. So, thinking of a case in the Toronto area where an individual, and this was in the news, so you can find the article online, was able, I believe he had ALS, and he was able to have MAID at home. And so had part of the protocol administered at home. So for him, his last memories and experiences were of being at home, and he was soon intubated after he received the second medication and transferred via ambulance to the hospital. And MAID was completed at the hospital, and he went on to the operating room to have his organs recovered. So it is feasible. It really comes down to the comfort of providers and the accessibility and literal closeness to hospitals that would be able to accommodate that request. But it's definitely something to ask about.
All right. Thanks, audience member. Next question. This audience member is curious, in your experience for people who are experiencing that fear of death or fear of dying, have you ever seen that fear or that anxiety dissipate as they get closer and closer to the actual moment of death? Just curious what your thoughts are.
Yeah, I don't think it's something that necessarily has to stay with somebody. I think the fear of the unknown is often the thing that is the most scary for humans in every situation, including dying. And so I think people often, and I see this a lot in my MAID assessments, is people have a very misunderstood or misperceived thoughts and feelings about what dying is going to be like. And so perhaps prepare for, a sudden increase in pain or uncontrollable pain, which was something we didn't really talk about in the interview section, but that just because you're dying doesn't mean you're going to have pain. So the dying process, as I've detailed, is just less of everything. It's less of being alive. It isn't actually painful. Yet media and movies and stories and old wives' tales have led society to believe that dying equals pain. And so I often see people for MAID assessments that their biggest concern is dying in pain. And I'm able to reassure them, if pain hasn't been a concern for you through your illness trajectory, it's not going to become an insurmountable symptom just because you're in the last little bit of your life. And palliative care is really good at managing pain, especially pain that hasn't been difficult to manage previously. And so I think for people who have an innate fear of dying, some of that may be related to, what is this decline actually going to be like? And am I going to be able to cope with that? Some of it comes from, this fear of not existing anymore. And I think that really work in order to deal with that can be done in regards to legacy work. So how can I be remembered when I'm not physically here anymore? What can I do with my time remaining that will allow me to live on? There are some cultures that think about dying in two parts. Your first death is when you physically die, and your second death is the last time your name is ever said. And so, how can you prolong the time between your physical death and your second death? And so, doing that legacy work can make people, a little bit more accepting of, I'm not going to be forgotten as soon as I'm gone. But there are people who really, really struggle and struggle right up until their last breath. And I will say, in my practice and my experience, that those patients have a much higher physical symptom burden than people who have come to terms with what's happening. They're just fighting against this thing that is going to happen no matter what, and their physical being responds by just being, a lot of pain, a lot of restlessness, a lot of agitation that is really challenging for them and for their family to witness. And so I think if you are one of those people, or you are caring for somebody who is really struggling with coming to terms with their dying, that having a therapist, a social worker, a friend, a hospice volunteer, somebody that this individual can share some of their feelings with, and just putting those feelings out in the world can do a lot, so that they're not ruminating and becoming this horrible, awful thing inside their head alone. Because we can't fix what's going to happen. We can't stop it from happening, but we can normalize how they're feeling. And that may be enough to help them to come to terms with this.
Thanks. Next question. This audience member asks, how can family members of a loved one that is about to die recognize when the care they're receiving is insufficient or otherwise unsuitable? I'm thinking of things like culturally safe care, for example. What are some tips maybe for how family members or, a substitute decision maker, for example, can step in and recognize when that care is not adequate, and how to advocate for that patient?
Yeah, that's a really hard question. And I think those situations will come out of an innate feeling of discomfort with the situation that your loved one is in, or the sense that you're getting from the care team or lack thereof of a team. And so I think finding the point person who's sort of should be overseeing the care. So for example, in the community, that would be a care coordinator who's overseeing the individual professions that are coming into the home, like nurses and PSWs and that kind of thing. Or it may be, the most responsible practitioner, whether that's a nurse practitioner or a physician, to be able to go to and share your concerns. I think one of the ways, and I'll sort of turn it around, because as a nurse, we often in palliative care talk about the patient dignity question. And something that we ask our patients is, what do I need to know about you to care for you better, to provide you the best care? What's something about you or your family that's really important for me to know about? And that allows the patient to share some information and lets them know that we still see them as a person that has individual likes and dislikes and things that are important to them. So as a family, you could turn that around and say, I just want to let you nurse, you PSW, you physician know that something that's really important for you guys to know about in our family is X, Y, and Z, or, something that we're really concerned about or that we're worried about or is are these things. And so being able to share that with them is a good opening way to allow that conversation to happen about, these are the things that we feel are important, and give them an opportunity early on in the relationship to sort of build off of that, so that hopefully you don't end up in a situation where you're feeling that the care that you're receiving isn't meeting your needs.
All right. Thanks, audience member, for that question. Okay, we just have about a few minutes left here for our session. So let's see how many we can get to. This audience member is curious about whether or not it's appropriate to cry in front of that loved one that's dying. I think some people might feel that pressure to be upbeat or to focus on that loved one's emotions and not necessarily be experiencing that grief in that moment for what's going on. So I'm curious what your perspective is in the deaths that you've witnessed.
So I this is such a great question because I think it's something that we overlook a lot. I talked about when someone's given a diagnosis, how they lose control and the feeling of having a sense of control over the remainder of their life. This is kind of similar. Imagine you knew what was happening. You knew in your heart of hearts that you were dying, but nobody around you acknowledged that that was happening. How lonely would that feel? What if you wanted to cry and you wanted to say things and you wanted to have an opportunity because you knew those opportunities were fleeting, and yet everybody came to you and, how are you doing today? How's it going? Oh, talking about everything except what is happening, right? And it doesn't mean that every conversation has to be this emotionally laden, heavy feeling, but it's okay to be emotional, and it's okay to give opportunities for the patient to be emotional, because if they can't be emotional and let their feelings and thoughts about what's happening to them known to their closest loved ones, who are they going to talk to about that? Right? They need an opportunity to grieve and to share their feelings and to say those things that need to be said. So I think if you get that feeling, I say this to my nursing students and NP students a lot, if you get a feeling intrinsically that there's a question that you need to ask or a thing that you need to say it. Ask the question, because that likely is the exact thing that needs to be said or the exact thing that needs to be asked. So I think it's totally appropriate.
Yeah. Thank you so much. All right, we have time for just one or two more questions. This audience member is curious, is the let's call it runtime, if you will, of a medically assisted death and a person who is perhaps dying naturally, if you will. Is there a significant distinction in the amount of time? Is the dying process itself, in terms of, again, that deterioration of the body's functions, is it similar? Is it distinct?
It's very different. I mean, it will depend on how far into the dying time somebody chooses to have a medically assisted death, but most of the time, when people are not using a waiver of final consent and making a decision about a date and being and able cognitively to give the final consent prior to medication administration, they are much more alive than somebody who is going to die naturally. And I think that's one of the reasons that often people give for wanting to have an assisted death, because that prolonged dying time, we don't know how long that is going to last. And that's a question I get quite often from family members, especially if we need if we're waiting on a family member to come or they need to make travel plans, how long do they have? Well, sometimes when someone is, literally comatose and could die at any moment, they can actually live in that state for days, sometimes over a week, sometimes 10 plus days. And so that length of time can feel really unpalatable for many people. To think that their family is sitting vigil watching for that length of time, expecting every last breath to be the last breath. And so converse contrast that to a medically assisted death where the person is most of the time awake and alert enough to say goodbye to their family members and knows exactly what's happening, and their body ceases functioning in less than 10 minutes. So they're very, very different.
Okay. All right. Well, that's it for time, folks. I want to thank all of our audience members for their engagement today, for submitting all of those questions. And Valerie, I just want to thank you as well for your time, your insights. Were so comforting for our audience. And I know I certainly learned quite a lot from today's session.
Well, it was my pleasure. And again, I want to commend everybody for attending today and for just being open to learning more about this lost art of dying.
Yeah, thank you. So we hope that you found this webinar worthwhile. It's thanks to the generosity of our supporters that we can provide webinars like this, as well as all of our other compassionate services, 100% free of charge to people across Canada. So if you enjoyed this webinar, we ask that you please consider paying it forward and empowering us to continue the work that we do by making a donation today. So thanks again for your support. Thanks again for your interest today. And stay tuned for our DWDC newsletter for future webinars, updates, and all things end of life. So thanks, everyone, and take care. Bye-bye.
Thank you.